मैं क्या करे तुम बता छोटे पैसा चले गए।
अच्छा
तब मैं बोला सर तो झूठी हो गया। सुहेल कहाँ है?
सोहेल आ रहे किसान साहब के साथ।
ये तो गलत है ना यार, हमको बुला लिए।
वो मैडम ने बोली मैं पहले ली थी बोल के वो आराम से आ रहे हैं क्योंकि उनका पहले था। तो आप पहले से ना
पहले चलते थे।
पहले से
बेबी का दर्द है। तुम्हारी बेबी को तुम लेके आए उसका तो बहुत ख्याल है।
तो
ध्यान दो बेटा, ऐसा रहता है।
गाड़ी का वीडियो बच्चा
त्याच्यानंतर पुन्हा पुण्याला नाही, आता पुण्याला माझं नेक्स्ट वीकला फॅमिली बरोबर आहे आणि नंतर कदाचित ते महाराष्ट्र
तो रोटेशन तो वहाँ ले लो से वहाँ पे ले जाओ।
महिन्यात 15 ठिकाणी 15-20 गाडी ते थोडं ह्याच्यामुळे पण होतं ऑफिस पण आमचं म्हणजे रेग्युलर आम्ही जे जातो दरवर्षी ते नाही, आम्ही पण मुलीमुळे नाही जॉब करत होते सोडला जॉब इमिजिएटली पासिंग आउट झालेलंच ते ग्रॅज्युएशन पोस्ट ग्रॅज्युएशन पुण्यातच राहून करते सर ते फार मोठा प्रश्न बाहेर पाठवणं नाही नाही ती तिचीच तयारी नाही ती म्हणे ते आपल्याला तेवढे पैसे टाकलेले मी
पैसे ठीक आहे आपण पैसे
सर पोस्ट ग्रॅज्युएशन काही हरकत नाही कारण बाहेरचं रिसर्च वगैरे जे
हे सगळं चांगलं आहे मॅडम
येत नाही That I agree, absolutely agree.
म्हणजे हे झालं आहे की
माझी पुतणी युएसला आहे,
आमचा मोठ्या
एक आयर्लंडला आहे.
तसंच पुढे पळवायच्या मार्गावरती सध्या आहे.
हो ना.
मोठा तसंच मला जायचं ग्रॅज्युएशन नंतर मी जाणार ना.
सर तुम्हाला तरी 2 आहेत, आम्हाला तरी एकच. मी काही एवढा विचार नाही. जाऊ दे, इज देअर लाईफ. माझं साईन ऑलरेडी केलंय की सर बसा ना, मी बसले. ॲसनचं स्पेलिंग चुकलं.
कसं काय म्हणतात
AHE लिहितात ते लोक.
AHESOL.
हां AHSOL. ऐसा नहीं है उशिरा जे रोटी सरांची 2 आहेत. हे डॉक्टर अजय रोटेंची 2 आलेत चुकून बहुतेक.
एक चेअरपर्सन झालं स्पीकरचा.
अच्छा 2 वेगवेगळे बनवलेत का तुम्ही? दिलीप ठोंबरे आहेत ना?
इतकं डिस्ट्रॅक्शन नाही
मला म्हणतात का
त्याला वाटलं त्याला वाटेल ना बाबा हे म्हणजे एकदम तेच करून टाकलं माझ्या नावात.
तुमचेच मित्र आहेत ना?
11वी वार
मला वाटतं MBBS तिकडचे आहेत का?
नाही तो आहे मूळचा पैठण म्हणजे ओळखीला म्हणजे हा बघ पण ठीक आहे रिलेटिव्ह लोक आहेत कोण होतं विजय काय काय होतं त्याच्यात
स्पीकर्स के लिए
ठीक आहे
स्पीकर्स के लिए मैडम बाकी डेलीगेट्स
बहुत गलत है सर क्या करो सुनो ना मैं क्या होता अभी फॉर द सेक ऑफ टाइम आपने ये प्रेजेंट करते समय लेट इट बी टेक इट बैक एंड प्रिपेयर यूर थोड़ा सा करना पड़ेगा ऑनलाईन 15 तुमच्या याच्यात पीपीटी लगेच सुरू होतं.
हो लगेच.
चेक करून आहे. ठीक आहे चला गुड मॉर्निंग ओंकार बस आमच्याकडे फक्त व्हॉट्सअप
कोल्हापूरला आमचे आहेत ना डॉक्टर राजेश देशपांडे डॉन नाही
डॉन सुपर डॉन
तुम्हाला 1-2 वर्ष
वय वाटतच नाही तसं तर बघून देते
तो नाही तेजसला पाहिले का तेजस नाही तो अजून एक बेन्सिलला पाहिले कधी असं तो तर अक्षरशः कॉलेज बंद म्हणतो परवा भेटला होता कयाकिंग केलं म्हणजे समुद्र दोघांनी
जुबेर शार्प 10-15 we will start yes sir ठीक है फिर क्या रहेगा आगे हमारे भी कंप्लीट 1 बजे के बाद में प्रॉब्लम नहीं होना वो भाई को बैठेंगे 1 बजे तक
भाई तो बैठना ही है। मोहित कौन कौन है आप? दोनों फ्री है ना?
काळे सरांची भेटच नाही
अरे सर सध्या
तो फ्री तो आता तुम ड्यूटी पे हो
ओपीडी बस
फ्री हर्ष और पार्थ तो नाइट ड्यूटी करे होंगे छोड़ दो इसी ठीक बताओ भैया तू बच्चा नाइट ड्यूटी करे तो बच्चे ड्यूटी में ठीक
चालू
एक बच्चा छुट्टी पे
पेशंट किती लागले जेवढं खूपच केलं
सीजीएमचेच करते तुम्ही आहेत ना
आमच्याकडे काय केले माहिती का आता एक साधारणतः थोडासा पेपर तपासायला काय करतायचं तर तुम्ही मी इंटरनल एक्झामिनर आहे कुठे बायाच्या स्टेटवरती यांच्याकडे पाठवून ज्याला काय पण येते ते फेल
गोविंदा बोल
जेवढे
अच्छा ठीक किसका है हेलो किसका है किसका किसका
लंच के सभी
तो क्या करने का है
आइडिया
बैठ जाइए हाँ तो वेंटी लग रहा
सेट झालं तर ठीक आहे बेटा लेट इट बी देयर इज ऑलवेज म्हणजे बॅड पॅचेस
क्या है रिपेयर करके
बट अदर वे राउंड सर कसे सर दिसता काय इंग्लिश
तो ठीक है मैं जगह बना के तो व्हाट्सएप
बोला तीसरा
हाँ हो गया क्या
मला म्हणायचं
नहीं हमारे पास तो हमने तीनों को फेल करे
आपने किए क्या नहीं हमारे पास किया नहीं हमने प्रैक्टिकल में उसको 62% दिए मैंने वही एग्जामिनर
हाँ
क्या था आपने फैकल्टी का बच्चा
हाँ और अच्छा बच्चा है
दैनिक 50-55% तो प्रैक्टिकल में बोले वो वाली वाले तो साल वो दो पुढे ना अनुज
चेयरपर्सन मैडम के लिए आप बैठूंगा मैं चेयरपर्सन पर काय माहिती का आजकालची ना अभ्यासाची मेथोडॉलॉजी बदलली. आपण काय करायचो माहिती का पुस्तक 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 आता पूरा मोबाइल
सर वो टैब पे चल रहा है सर, सब टैब पे चल रहा है.
हमारे भाई ने तो टैब लिया एप्पल का मैकबुक लिया बट मैं क्या बोलता मेरे
सर
को
वो राजे है ना सर, वो राजे तो वैसे तो लेना ही पड़ेगा.
नहीं वो राजे है वो बात सही तेरी
वे बरोबर बोलले.
तो सुनो ना तो उसको मैं बोला मुझे मालूम नहीं मेरे को 0.8 से नीचे सीजीपी जाना नहीं तेरा.
अच्छा.
फर्स्ट ईयर में 0.86 आया
अच्छा.
और अच्छा ठीक है मैं कुछ बोलूंगा नहीं तो कुछ भी कर लेकिन थोड़ा क्या रहता मुझे चेक रखना पड़ता
चेक रखना पड़ता.
चेक नहीं रखा तो फिर थोडं जरा मस्ती में आने लगतो.
मुलांचं असतं, मुलींचं एवढं
नाही नाही
नसतं.
पोरांचं मॅडम पोरांचं संगोपन करणं म्हणजे इट इज द टफेस्ट थिंग. तुम्हाला सांगितलं पण माहिती सगळं असतं.
मुली ऑलरेडी सेन्सिटिव्ह असतात थोड्या.
सेन्सिटिव्ह आणि सिन्सिअर पण असतात. म्हणजे मुलाच्या तुलनेत मी सांगेल खूप सिन्सिअर असतात मुली.
सर आजकल लड़के पढ़ भी नहीं रहे सर. आप देखो कितने
थोडंसं
बच्चे.
झालंय.
अरे पूरी एक बार तो
इवन इन एमजीएम.
अपने पास ही बोल रहा है अपने पास ही.
सर ते सगळ्या इन्स्टिट्यूटमध्ये आहे, मी बघतीये.
नहीं आमच्याकडे जास्त नाही.
हॅलो
ते सगळं कॅम्पसवर मिळाली लागले.
समोरच मिळालं.
का बरं
हाच प्रॉब्लेम आहे.
नाही का बरं
आणि काय होतं त्यांना कदाचित कनेक्टिव्हिटी नसते फॅमिलीशी.
नाही 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 कोणी पेशंट असेल तर उद्या सकाळी 12 वाजता. उद्या रेग्युलर टाइम उद्यापासून एमजीएम सुरू होतं ओपीडी टाइम 12 वाजता सुरू होतो. नाही का बरं नाही काय म्हणे ठीक
तुमच्याकडे येणार आहे सर ह्याला अप्लाय करणार आहे ना मी इथिकल करणार तिला करू शकतो. मी पीएचडी करते
अच्छा.
तिकडे बायो इन्फॉर्मेटिक्स.
अच्छा.
गाईड कोण
हरके मॅडम चांगले आहे.
हा मित्र
मग मॅडम मेडिसिन किंवा इथे डायबिटीज मध्ये करून टाकायचा पीएचडी.
हा म्हणजे मला त्याच्याबद्दल नाही तसं नाही.
हाँ मेरे को क्या लग रहा है कि दिमाग को टेंशन का बढ़ा देगा काले बोली कितना जिंदगी में 50 साल हो गए ना कितना पड़ेगा बस.
नाही तुमचं म्हणणं बरोबर आहे पण मी काय जे
तुमचं वय कमी आमच्यापेक्षा आम्ही आता
2 वर्षात त्याच्यामध्ये
ठीक आहे. आता खरं सांगू ना नाही ओळखता
सर तुम्ही खूप काम केलंय तिथे एमजीएम आणि हे
आम्ही खूप
सगळं
केलंय का
त्या रिलेटिव्हली मी माझं घर
तुम्ही भरपूर काम करता मॅडम नाही असं नाही आय रिअली अप्रिशिएट युअर एफर्ट्स बहुत
नहीं
गुड
सर सर इतने प्रैक्टिस के साथ फैमिली संभालना इट्स नॉट इजी.
तुमचं आणि एक कसं असतं महिलेसाठी कधी घर पण एक जॉबच आहे.
गुड मॉर्निंग.
गुड मॉर्निंग
गुड मॉर्निंग.
गुड मॉर्निंग पैसा
10 बजे का टाइम.
बट
ट्रैकिंग करके
Oh,
आगे.
yes.
जैसे मैं दिव्य मराठी का वो आया ना भी मेरे को व्हाट्सएप पे आया और सबके इतने लोगों के नाम डाला उसने सब कुणी काय काय म्हटलं सगळं लिहिलं तरी
बरोबर.
मैं तो मेरा फोटो देखे मला यार खरा आमदार खासदार वाट लागलो. हे बघा इंदुरकर सर त्यांनी तसेच फोटो घेतलेले तिथेच बसले होते सगळ्यांचे सबके. हे बघा ऐसा नाही हो ते
स्मार्ट है वो.
सोहेल क्या पठाले सर निळ्या ड्रेस वरती
त्याच ड्रेसवर.
एक तुम्ही
हो, मी same.
रात्रीचे जेवण टाळा.
तुमचा लॅपटॉप आहे
आणि आपण स्वतः 9ला जेव्हा रात्री.
तुमचा लॅपटॉप आहे
माझा आहे
हे
माझा.
अरे सुनील डोळे बंद करा.
हा, त्यांनी सांगितलं सुनील
कशासाठी?
प्लास्टिक इज an endocrine disruptor.
अच्छा अच्छा अच्छा
So that will cause changes in insulin levels and leading to increased propensity for diabetes. So
प्लास्टिक मुळे
एंडोक्राइन डिसरप्टर, देयर आर सम मॉलिक्युल्स, मी नाव विसरले, ते सगळे 3-4 मॉलिक्युल्स आहेत ते एंडोक्राइन डिसरप्टर.
सगळे लोक कव्हर केले टू झेड, सगळे लोक कव्हर केले त्यांनी.
ओके.
ठीक आहे.
आणि त्यांनी लिहिलं ना, तळमळीनी सांगितलं, खरंच तळमळीनी सांगितलं ते मध्यभागी लिहिलं वगैरे. ते पूर्ण नाही वाचलं, तेच मेन वाचलं, बाकीचं माझंही नीट नाही. सर चला.
जुबेर, आई थिंक विल स्टार्ट क्योंकि क्या रहेगा, तुम्हारे ऑनलाइन लोग परेशान ना हो, तो लॉगआउट होना शुरू कर देंगे.
Good morning, everyone. Welcome to the Insulin Summit 2025. I, Dr. Zubair Khan, on behalf of Elite Education and Welfare Society, Jews Indian Institute of Medical Science and Research, and Aurangabad Diabetologist Association, welcome you all for this academic feast. Today, we will be learning, discussing, and having a clinical insight of what is insulin, how it is to be used, and recent advances that is to be known into the insulin. So let's begin with our scientific session. For that, I'll call upon to chair the session Dr. Tuba Fatima Madam. She is Professor and Head for Pathology in Indian Institute of Medical Science and Research, and Dr. Deepak Bhusle sir, who is Consultant Diabetologist at the Devgiri Diabetes Center and Professor and Head at MGM Medical College for Pharmacology. For the talk, I request Dr. Mayura Kane Madam to kindly take the dais. I request Dr. Tuba Fatima Madam to kindly introduce the topic.
Thank you, Zubair sir. First of all, I thank the organizers to give me this opportunity of chairing this very interesting session, which is on interpretation of CGMS reports, that is continuous glucose monitoring reports. CGMS provides a wealth of real-time data, but effective use depends on correctly understanding metrics such as time in range, variability, patterns of hypo and hyperglycemia, and actionable trends. Accurate interpretation helps us individualize therapy and improve patient outcomes. To guide us through practical and clinically relevant ways to interpret CGMS data, I invite our respected speaker, Dr. Mayura Kane, to begin the session.
Good morning. To begin with, actually, I would like to introduce Dr. Mayura Kane. She's a young, dynamic diabetologist from Chhatrapati Sambhajinagar. I think actually all of us know her. She's one of the active member of National RSSDI, and she's a national faculty across, she's roaming across pan India to deliver talk on different aspects of diabetes. So I requested her to deliver specific talk on this topic, where actually many of us are doing this CGMS in clinical practice, but we find it difficult to interpret the result of CGMS. So let us listen from Dr. Mayura Kane. What is the CGMS and how to interpret the report of CGMS? Over to you, ma'am.
Yes, thank you so much, sir, for the kind introduction. Thank you, madam. Thank you, Elite Academy, Dr. Zubair, and I welcome everyone on behalf of Aurangabad Diabetologist Association. So my topic is basically today we are having an Insulin Summit. So we'll be talking more about how to use insulin and rest of the things associated with insulin management. But we thought we will have some update about CGMS, which is a little newer thing. Maybe many of us are using since last more than a couple of years. And it will help us in management of insulin therapy. So now starting with how to interpret CGMS. So I will just, this is my outline. So why to move beyond HbA1c. What is CGM-AGP? What is TIR? The present system is Libre2, which is a very commonly used, though we are using Sinocare, few of us are using Sinocare since last few months. What are the clinical evidences and how it is the connected care system? So first, moving beyond HbA1c and SpA1c. So we all have been traditionally working on diabetes management, and what we are doing first is we know very well that we have to better manage the overall blood glucose levels leading to better HbA1c. We have to, obviously, it is a very important that we avoid hypoglycemia, and the most important thing is, I would say, to limit glucose variability. Glycemic variability is one of the important factors for this complications of diabetes. So we know very well HbA1c doesn't tell full story. It is though it is a key indicator, we are still using it. It's a gold standard for us, but still it doesn't tell us the full story, because it doesn't reflect the acute glycemic excursion of hypo and hyperglycemia. So we don't know if today patient has gone into hypoglycemia and he has good HbA1c or high HbA1c. We won't be able to predict with HbA1c that problem. It fails to identify all the intra or interday variations. So yesterday patient was very well controlled, and today he or she is not controlled. That will not be recognized. Conditions such as anemia, hemoglobinopathies, iron deficiency, pregnancy, they confound these HbA1c measurements. So we know that the RBC span is around 120 days, it's 4 months, but usually we see it varies from 90 to 150 days. So depending upon that kind of HP level as well as the hemoglobin glycation index. So even if the blood glucose levels are normal, patient may have higher HbA1c, and the blood glucose levels are high and there will be normal HbA1c. It is because the affinity of that glucose to bind that hemoglobin molecule that is varied person to person, and that is why hemoglobin glycation index is also important. So HbA1c doesn't tell us full story. Here you can see the first diagram. Over here you can see almost flatter profile, though there are some fluctuations, but as compared to the second graph, you can see there are a lot of fluctuations, but the HbA1c is same. So that is why we can say that HbA1c doesn't tell the full story. The glycemic peptide reserves a prominent position in diabetes management. So besides fasting, boosted HbA1c, glycemic variability, and more importantly, quality of life. So with treatment, with blood glucose level, normal blood glucose level, whether we are really offering, I have achieved very good blood glucose control, but is it really reflecting in the quality of life of that patient is very important, because we should always be patient-centric and not only the lab or reports. So what is glycemic variability? So glycemic variability is basically there is similar mean glucose levels. There are differences in terms of the number and degree of glucose excursion. So this is called as glycemic variability. So here you can see the yellow graph. So this is high glycemic variability. So sugars are fluctuating very up and down very fast. So maybe more than 100 to 150 milligram per deciliter within a span of few hours. So that is glycemic variability, and it is a factor associated with diabetic complication. How do we measure glycemic variability? So we have to measure the glycemic variability with continuous glucose monitoring, because there is no other way to precisely measure glycemic variability. And CGM will provide us the measure. It will be useful to see the glycemic variability. What is continuous glucose monitoring system? It's a very tiny sensor which is placed under the skin, usually the arm or belly, and it measures the interstitial blood glucose level. So what is interstitial blood glucose? It is the glucose found in the fluid between the cells. That is interstitial blood glucose level. And it with a sensor test that whatever sensor that goes into the filament goes into that interstitial fluid, and it tests the blood glucose. Interstitial blood glucose every few minutes, and it transmits the information to a monitor, and the monitor may be a part of insulin pump or separate device. So we are not using much of insulin pump, but yes, we are using this CGM as a separate device, very, very common. So evolution of glycemic management. So first figure, this one is, you can see, so HbA1c, the left first on left your side, the practice which we would do now also we are doing it, but At the right side of the screen, you can see the new glycemic targets. The green is time in range. So how much time the blood glucose is within range, that is time in range. Level 1 hyperglycemia, level 2 hypoglycemia, light yellow, dark yellow. And you can see, yeah. So here, this is time in range. This is level 1 hyperglycemia, level 2 hyperglycemia, level 1 hypoglycemia, level 2 hypoglycemia. So SMBG provides, we know very well, the measurement at a single point. So here you are measuring blood glucose, here you are measuring. So you are seeing the blood glucose levels are within normal limit. But when you put a sensor, you will understand that it is going down also in between, and it's going up with having a lot of glycemic variability. So this cannot be detected with SMBG, and we know very well there is pain and inconvenience, which is really major limiting factor in our patients with diabetes. So recommendation of SMBG is usually 2 to 3 times a week, but in real life 3 to 4 times a week this is done. I mean, this is a very, I would say, very stringent study, but in our patients, I don't think anyone really does. Very few, only 5% max patients will be doing 3 to 4 times a week, and it has results in glycemic control. So what is CGM? And the CGM is this. So I think those who have used, they know very well. So this is Lancet, which we are using for pricking for the SMBG or the with glucometer, what we do. This is a sensor, and you can compare this. This is a very, length is also small and the diameter is also very less. Then it goes into the subcutaneous space, and this is the usual blood glucose vision measure. This is blood glucose with the Lancet, and this is interstitial blood glucose, which is seen with the sensor. So the sensor continuously measured from beneath the skin by a tiny filament attached to the sensor, and the tiny filament under the sensor is as thin as a strand of thread. So those who are putting it, they know very well that it's a very thin. This is how it is put. You can see over here, it is put over, and you can scan with the mobile, or we have readers also, but I think it has been stopped by most of the companies. The readers have been stopped now and may not be available now. And it will allow us to see the trends and patterns, highs and lows. It will help us to avoid low glucose and titrate insulin dosages. So this is CGM can lead to actionable insights beyond SMBG. How does CGM help us? If you see this very clearly, these are the day graph. So here you can see this is very high. So this gray line, if you see, this is usually set between 70 to 180. And this is called as time in range. If it goes below, above this, it is called as time above range, and you can see very well, this is something, if patient has eaten something and it has gone a little up over here. Here, this is same over here, this is high, high, high. So you can approximately say that here, this is maybe breakfast, this causing maybe a high blood glucose level, this is lunch, and this is kind of dinner, little earlier dinner, you can say. And here you can see this is on the lower side. The red is on the lower side, and that is time below range. And this is probably early morning hypoglycemia in this patient, or midnight to early morning hypoglycemia. And here you can see the details are also here over here. So time, this is red is time below range, yellow is a time above range, and this is time in range. We will discuss these things further also. So this is ambulatory glucose profile. So CGM is the continuous glucose monitoring, and ambulatory glucose profile is it's a modal day plot, and it collapses glucose data over several days or weeks. That is called as ambulatory glucose profile. So here you can see this is a data of around maybe 14 days or so, and this is the average of those 14 days. Yeah, this is very important graph, I would say, and one should know about this. So this is, first of all, this is this line between these two lines. This is 70 and this is 180. This is called as target range. Then this line, you can see the dark line, that is median blood glucose levels. So median, you know very well, median doesn't mean mean. Median means median. So when we start from 1 to 0, the middle point is called, 0 to 1 to 100, the middle point will be called as, depending upon the values, how we plot, ascending or descending order. So ascending order, this is the median value. So when you see the dark purple, so this is 25th percentile curve and this is 75th percentile curve. And this interquartile range will be obviously 50% of the data. This, when you go a little above and little below, this is the below one is the 10th percentile curve and this will be the 90th percentile curve. So this total from here to here will be the 80% data. Here also approximately you can say something that this is 10 AM, around before that the blood glucose levels are getting higher all the time, almost all the time. Here it is going little normal, here little normal, but again going little up over here, little up over here. This is approximately, but yes, we should know what is median, what is 25th and 75th percentile, and we should know that this is 10 and this is 90th percentile. This is very important. So what is time in range? As I said just now, this 70 to 180, this is the usual target range and this is called as time in range. When it goes above 180, that is called as time above range. When it goes below 70, it is called as time below range. These three terminologies, time within range, time above range, time below range, this is a very, very important terminology and we should know, especially those who are studying or those who are into research and even in clinical practice, they should know this much at least so that you can explain to the patients what is their time in range. So, time in range includes three parameters, as I said. This is time in range, TIR, below range, time above. And there are clear-cut targets, that is, the time in range should be more than 70% of data that is captured over 15 days of the sensor wear time. This 70% figure is also very important. Yes, this as clinicians, we should know. First is the category of type 1 and type 2 diabetes. More than 70% should be the time in range. Level 1 hyperglycemia should be less than 25%. This should be level 2 hyperglycemia should be less than 5%. Level 1 hypoglycemia should be less than 4%. Level 2 hypoglycemia should be less than 1%. This is a standard practice. But certainly, if one has little more of time in range and little less of all these other four things, it is always better. When we talk about little elderly patients with type 1 or patients who are having little high risk, lot of complications, there we may have little bit relaxed goals that time in range can be up to little bit more than 50%. Pregnancy with type 1 diabetes will have almost similar goals as type 1 and type 2 diabetes. And very importantly, pregnancy in type 2 diabetes and gestational diabetes. This time in range should be as high as possible. I would recommend more than 95%, if possible 100%. That is very important. So here you can see this is a correlation of time in range with the HbA1c. And 10% increase in time in range, that is controlled blood glucose level, will have 0.8% reduction in the HbA1c. And this 70% target which we are talking about at present, it strongly correlates with the HbA1c goal of around less than 7%, that is 6.7% around. So if you are 90%, it's almost the blood glucose, the HbA1c will be around 5.1%. This is, time in range report from CGM. So you have to see this is, so time in range I said more than 70%, below 70 milligram less than 4%, and below 54 should be, this is the hypoglycemia time, severe hypoglycemia time should be very less, I would say less than 10 minutes, but yes, if it is 0, it is very good, obviously. And this also again, the high blood glucose level should be less than 1 hour 12 minutes, but obviously as less as possible. That is very important. ADA recommends the use of standardized report with TIR. So we should have such good report. I mean, mention everything is mentioned in this. The report should be there. The TIR and AGP facilitate the development of safe and effective care plans for people with diabetes. This you can see what is the importance. So 64%, there is a study of these patients and 10% reduction in TIR. So time in range, जितना कम ही हो जाए in range, there are increased chances of complications. So 64% increase in the retinopathy, 40% increase in the microalbuminuria. Here also you can see in the retinopathy. So with increasing, decreasing TIR, increasing rate of complications will be seen. Again, mortality will be more, all-cause mortality as well as cardiovascular mortality. Will be TIR may be surrogate marker. Obviously, they have not studied the TIR for such a long duration, but they have with some other studies and they have put this inference that TIR may be a surrogate marker of all-cause and cardiovascular disease-related mortality. Lower TIR is also associated with, again, mortality and plaque build-up in carotid arteries. These are the complications again. You can see this. So if this is compared to CGM and the blood glucose level, here another thing is continuous glucose monitoring, use of continuous glucose monitoring. It reduces the CV complications of the blood glucose. So blindness was less. This yellow is with CGM and you can clearly see with compared to the dark brown, the rate is less. So blindness, congestive heart failure, myocardial infarction, renal failure, stroke, everything was less with the use of CGM. It's a potential measure of therapeutic success, obviously, and A1C or CGM management. So obviously, if possible, we'll use CGM in HNP patient for as much as possible, but certainly because of cost constraint, it may not be possible. So what are the immediate benefit of CGM? We will avoid very high blood glucose level, we will avoid hypoglycemia, and obviously admissions will be avoided. And long-term benefit, we have already seen the reduction in the complication. And the growing body of evidence demonstrate that CGM improves, causes reduction in HbA1c, reduction in hypoglycemia, increased time and range, decreased hospitalization. The quality of life and satisfaction is increased, and very importantly, the absenteeism is also decreased. All the international associations, they recommend use of CGM. This is a new system which we are using, the Freestyle Libre 2. We have used previously the Libre Pro, which had a lot of another problems with Libre Pro. Libre 1 also we have used, and now we are using Libre 2 Plus. So I'll tell that also later on. It's a very good, I would say, good state-of-art manufacturing, smart quality checks, trusted data security, commitment to the customer care is there by them. It's a reliable, accurate, and it's a very user-friendly. I will talk that. Yeah, this is very important. This sensor is put to the patient. This is the reader, but now we are not using reader that frequently. And this is the mobile phone which the patient uses to scan the blood glucose levels. So once this is scanned, there are two ways it can be shared, data can be shared. So this particular patient who has put that CGM can share with the Libre link up. That means he or she can share with the relative or whomever he wants to share. And this is Libre View for the healthcare professionals. So this is with us. This system is with us. We have separate login IDs and all. And once we log in, the patient who has connected to this, we can see the graph very nicely, and we can monitor remotely what is happening with the blood glucose level. By caregivers, sometimes there is very low blood glucose levels, and this may not be detected by the person himself or herself, but it may be detected by the caregiver, especially in children with type 1 diabetes, because they are not aware if they are playing or they are in the school. They may not pay attention to the blood glucose level. But certainly, the parents can keep watch on that and prevent hypoglycemia or very high blood glucose levels. So this is real-time glucose reading update. This is Libre link up you can have, and there is accuracy. This is also one of the most important thing I would say. that is MARD. So previously sensors, which is Libre Pro or Libre 1, they had a little bit. Libre Pro had quite high MARD, but Libre 1 has little less. I'm not sure about Sinocare, the MARD. They have not really, I just don't know, I can say that much. MARD is mean absolute relative difference. So what is mean absolute relative difference? When we see the blood glucose level with the sensor, at the same time, if we see the blood glucose measurement, we do the blood glucose measurement, what will be the difference? That is called as MARD. So to put in common language, that patients ask us that if we compare the glucometer, the glucometer value with the lab value, what is the difference? So most of the patients, they keep on asking, how reliable is this glucometer? How reliable is this glucometer? So we decided depending upon the MARD, and this new system has got a good MARD, that is 8.2% in adults and 8.1% in pediatrics. Ideally, the MARD should be less than 10%. But certainly, the less the MARD, it is more close to the lab value variance. So this is accurate, stable, and consistent for the entire wear period. And we can have anytime, one can have or scan anytime these sensor. The clinical evidences, the Freestyle Libre is one of the most used, you can say. Sinocare is still launched, and there are a few more launched, but we need validation for those sensors. And it is clinically proven in both type 1, type 2 diabetes. I'm not, there's no conflict of interest over here, so I'm not going to get anything from Libre, but still I'm telling about, because I have been using it more, that is why I can tell you. And both hypos also, it will improve the timing range, and it is proven to improve the glycemic outcomes in people who are treated with oral antidiabetic therapy, GLP-1 receptor agonist therapy, as well as insulin therapy. So everywhere, it is, even insulin dosing decisions can be made. So here you can see that the graph, if this is for bolus insulin, this is little below range going initially after the meal, then you can reduce little bit of bolus. It is going above range, you can increase little bit. Here it is going above range and still it is extended for a longer time. So that means that one has to evaluate the blood the content of the meal also. If it is very high carb, and we have to reduce that. And in sometimes maybe basal dose also we have to adjust. If it is going below range, in the fasting lab especially, we have to adjust the basal insulin. It is going above range, so it is like maybe you can increase the basal insulin dose. It is going to good, but it is the effect is going away. So kind of dawn phenomena over here you can see. So the cost of diabetes therapy obviously increases. If we use CGM, and we may be reducing the hospitalization, the complications, and the like macro and microvascular complications, and maybe people save a lot of cost over there. In gestational diabetes also, we are using very frequently. I think Indulga sir is using quite a lot in GTM patients for blood glucose control, and it is a very good device for that. It is discreet. Connected care system, we have already spoken, that is Libre Link Up and Libre. This is for patients, caregiver, and healthcare providers. So what happens, as I said, the sensor, the reading to Libre View, and we read it and we give advice to the patient. So this is a kind of very positive cycle leading to good change in the blood glucose levels. So these are the easy uploads, and you can see all the whatever is happening. I'm just skipping it because we have already discussed this. This is one thing which we have to see. This is very important. 3 easy steps. First is glucose statistics. What we should see in the report. 3 easy steps to identify glucose patterns and trends in the AGP report. This percentile CGM is active. So it should be at least 70% of the expected values must be present. That is 10 out of 14 days. But certainly we will tell it should be 100% because the patient is putting so much of money into that, so much of effort. So it should be active for more than at least 70%, but 100% is good. These are the ranges we have already discussed. This is average glucose, that is 7.8 millimeter, but this is one thing, these two things I wanted to discuss, that is glucose management indicator. What is glucose management indicator? That is, if the blood glucose level, which is shown in that graph, remains same for 3 months around, so that would be reflect the approximate HbA1c. So that is GMI, what we call glucose management indicator. And the glucose variability, as we said, the glucose goes up and down, and that is calculated with the sensor, and that should be less than 36%, but ideally as less as possible. Maybe even if it is 15 to 20%, that is also very good if possible. Second thing, time in ranges, which we have already discussed. And third is ambulatory glucose profile. To see all the graph together, that is ambulatory glucose profile. To summarize, CGM provides a dynamic real-time glucose data, and it will detect the glycemic variability, hypoglycemia, hyperglycemia earlier and lead into better management. You can use it in type 1, type 2 insulin users, non-insulin users, leading to enhanced patient engagement in self-care. The TIR, the glycemic variability, the patterns, they allow us to move beyond HbA1c levels, and it certainly enhances patient education, personalized feedback, and it supports shared decision making, especially when we have to address the barriers such as device cost, data overload, and patient convenience. So thank you very much.
As always, excellent presentation, but you have given comprehensive coverage of interpretation of CGMS report. So, session is open for discussion. Any question from audience? Before question comes from audience, one is regarding use of this device in anemia, because there are paper published of late saying if you are using CGM device in patients who are having anemia, it is giving more beneficial inputs for clinician as well as patient, because it has been documented if patient is having anemia, the value of HbA1c comes curiously high. Yes. So I think that is one of the indication where actually one should more and more rely upon the device like CGMS, or maybe patient is not affording CGMS, then SMH.
Yes, agreed. I mean,
rather than
yes, HbA1c, most of the times anemia will overestimate HbA1c, it will show higher value. Maybe there are no papers, not much papers about specifically about the hemolytic anemia and the megaloblastic anemia, but certainly this iron deficiency anemia and thalassemia, they will certainly overestimate the HbA1c values, and so we commonly get the iron deficiency anemia. Even if it is megaloblastic anemia, there is part of iron deficiency anemia always because of decreased appetite in those patients. So yes, sir, very well said that it is a very good tool in people who are having anemia.
Effect of anemia on GMI, any data? GMI, anemia and effect on GMI, as you said, A1C is curiously high. Glucose management indicator.
Especially that has been documented in pregnancy. Basically, what happened in pregnancy in second trimester, because of hemodilution, you may get actually altered value of HbA1c. So that's why even it is recommended, as you said, in pregnancy you should rely more upon CGM data or maybe SMH data rather than doing HbA1c value.
So I was asking effect on GMI. So basically, I have not come across any papers as such, but if we think about physiologically what we are doing CGM. So CGM values are there, and GMI is, you can say, calculated from CGMS values. So it should not ideally affect the GMI values.
Rather, of late actually they have changed the terminology. If you see when we were using the retrospective CGM, so that time it was HbA1c value in CGMS report, but again it was creating a confusion. Patient used to come up with the HbA1c report, sir मेरा इधर 9 आया और आपकी रिपोर्ट में CGM की रिपोर्ट में ये दिखा रहा है कि 8 आया. Why this difference is there? So that's why actually that terminology had been changed to glucose management index.
Yes, they would write it previously as estimated A1C, EA1C, and now they are writing only GMI. They have stopped it.
Any other question?
There's an online question regarding, can you please enlighten on insulin resistance? They are asking. Okay, insulin resistance and difference in CGMS.
So insulin resistance, when we talk about, it is like high insulin levels, and because of insulin resistance, there is hyperinsulinemia. So ideally, CGM will not have anything. CGM will have only it will give us only pure blood glucose values. Once, so if there is insulin resistance, hyperinsulinemia, high blood glucose level, they will be reflected. Once insulin resistance is corrected, there will be low, blood glucose level may be get corrected and we may get better values on the CGM. But per se, talking about insulin resistance and CGM, there is no direct connections. That's what I feel.
Yeah, CGM gives only blood glucose, no relation to insulin levels.
Any other question? Thank you.
Thank you so much.
With this, I would like to request our chairperson to kindly felicitate our
15 मिनट में खत्म कर दूं
उससे ज्यादा भी मत लो, कम भी मत लो.
आधी ऐसा तुम्हारा नहीं
I request Dr. Shafi sir, President Elite Executive, to kindly. I request Dr. Shafi sir to kindly felicitate our chairperson.
सकाळ दुपार संध्याकाळ फक्त भाकरी खायची दुसरं काही खायचं बाहेर टीव्हीवर टिकून
काही दिलंय.
तुझ्या फोटोच्या वर लिहिलं भाकरी करून ठेव फक्त भाकरी खायची.
मी असं काहीच बोललो नाही.
So thank you very much.
पहिलं जातं
मॅडमला जायचं.
Our next section is for insulin therapy, conventional versus analog. For this, I would request Dr. Ehsan Sheikh sir and Dr. Umar Hadi sir to kindly chair the session. Dr. Ehsan Sheikh sir is diabetologist at Kushi Hospital, and Dr. Umar Hadi sir is consultant diabetologist at Icon Hospital and professor at MGM Medical College. I now call upon our speaker, Dr. Mohammad Suhail sir, who is professor at Indian Institute of Medical Science and Research and consultant diabetologist at Shifa Clinic since 2013. Sir has got clinical experience at Shifa Hospital, JJ and GT. Sir has got research papers of around 13 in number, and he is interested in research on autonomic dysfunction in diabetes and diabetic neuropathy. Sir, kindly take the dance. I would like to request our chairperson to kindly introduce the session.
Good morning. Our second session is focusing on insulin therapy, conventional versus insulin analog, in key areas in diabetes management. Conventional insulins have been the backbone of therapy, while analog insulins offer improved pharmacological profiles and greater dosing flexibility. Understanding the pros and cons of each helps us to individualize the treatment and achieve better glycemic control. To take us through these practical differences and their clinical relevance, I now invite our speaker, Dr. Mohammad Suhail, to begin the session.
Thank you. Thanks a lot, Dr. Mohammad Suhail is a consultant diabetologist of vast experience of 10 to 15 years in the field of diabetology. He has got a good experience at Saifi Hospital, JJ Hospital, and is managing diabetes since last 10 to 15 years at Shifa Hospital in Shahbazar, Sambhaji. So, welcome, sir.
Thank you, thanks a lot. Actually, it's my absolute honor and pleasure. I'm very thankful and grateful firstly to Aurangabad Diabetologist Association and especially the seniors like Insulin sir, Rohit sir, Osle sir, SR sir, Umar sir, as you gave me an opportunity to present in front of you small topics. And next, I am really thankful to Elite CME Academy, specifically and categorically Dr. Shafi sir and Zubair sir. When I was going through the slides, I went through the history of insulin. And when I look upon Dr. Banting and Best, the second two figures and face which were coming into my mind was Shafi sir and Zubair sir. How Banting and Best tried hard to bring the insulin molecule to the world. Now today they have Dr. Shafi sir and Zubair sir have tried hard to bring Insulin Summit in Chhatrapati Sambhaji Nagar. So with this we'll start conventional insulin and insulin analogs. As we all know that prevalence of diabetes is rising with each passing day. Initially it was thought that from 83 to 86 million it will become around 90 million, but ICMR data came with the fact that today in India we have more than 10.1 crores of diabetic population, and the number of pre-diabetic is even more. And we have become almost like a diabetes capital. And in upcoming slide we can see, and we can make it sure that we can become a disease treatment capital from the disease capital. So as we all know, in diabetes, insulin is essential. It is a lifeline for type 1 diabetic patient, and there is no other therapy in type 1 diabetic patient. And type 2 diabetic patient also, whenever the other systems fail, like if there is a secondary failure to oral anti-diabetic agent, ultimately patient beta cells are exhausted and patient is going to need insulin at some point of the other. Or if the patient is having acute complication, like if he is in urosepsis or any other sepsis or tuberculosis, meningitis, ultimately both type 1 and type 2 diabetes patient will eventually require insulin therapy. And before going into the pharmacology or clinical aspect, one must be well versed with my alma mater, the physiology of insulin secretion. As we all know, the insulin secretion occurs throughout the day in different phases. One is basal secretion, which is a small amount of insulin, 50% of insulin, which is being secreted at a constant rate. That is called basal insulin secretion from the beta cell of pancreas. And then there is prandial insulin secretion, which you can see the peaks over here. With each meal or a snack, there will be release of insulin from the beta cell of pancreas. On average, in a healthy 70 kg man, one produces 45 to 50 units of insulin. And in your clinical practice, you might have seen that there are few patients who are requiring 120, 130 units of insulin in a day. So in a physiology where insulin resistance is not there, there is normal physiological insulin release. The insulin total requirement is 45 to 50 units. But in an insulin resistant patient, it becomes high, and it may go up to 1.5 or up to 2 units per kg. And one more thing over here is that different pharmacology preparation of insulin are available. In the diagram, it is shown that degludec insulin, it is in the vial or in the prefilled syringe. It is available in dihexamer. It goes into the tissue and it forms multi-hexamer, and gradually it disintegrates into dimer and monomer, and then gradually it goes into the circulation. Which type of insulin is needed for diabetes management? So ideal or holy grail of insulin, most ideal insulin will be which mimics the physiology, which covers the basal insulin secretion and the prandial insulin secretion. Achieve better fasting and postprandial blood glucose, and it minimizes the hypoglycemia risk. That is also very crucial because hypoglycemia at times is very dangerous and deleterious for the effect of health of the patient. It can trigger deadly arrhythmias and cardiac arrest. This is a very crucial and important slide. As you can see from the timeline, that the journey of insulin, it started from 1869, where Paul Langhans discovered islets of Langhans. Then in 1921, the Frederick Banting and Charles Best came, they discovered the insulin. It's a very long story, and we may need a 30 minutes of separate session for history of insulin. And then Leonard Thompson, a boy was given insulin in 1922, and he lived for 13 more years. So in that time he received the conventional human insulin, and we can see from this point lot of hypoglycemia episodes with the conventional insulin and HDL. If we want to avoid the hypoglycemia, we used to reduce the dose of conventional insulin. That leads to hyperglycemia. So all the time the insulin and sugar balance kept on fluctuating. So if you decrease the dose of human premix insulin, what was happening? Hyperglycemia, increased risk of complications. And if we reduce the dose, what glycemia. So that led to development of prandial insulin or insulin analog. They are developed to overcome slow absorption of native human insulin, provide faster onset within 15 minutes before meal, and better match post-meal glucose spikes, and they support high insulin demand during complications. And now you can see at the bottom of the table that time of action, time of onset is very fast. Dispro time of onset is 5 to 15 minutes, aspart 10 to 20 minutes, and glucose is 20 minutes. And time to peak is 30 to 60 minutes. And duration of action is also very fast, 3 to 4 hours or 3 to 5 hours. In this slide, I am trying to explain you that how these insulin analogs are made. I would not go much into the pharmacology of that. Grossly, these are made by just tweaking the position of amino acid in insulin chain. As we all know that insulin is having 51 amino acid, A chain and acidic A chain and B chain. Where engineering is being done and there is inversion of native B28 and B29 proline lysine sequence, then there is formation of glycyrrolase. In aspart, B28 proline is replaced by aspartic acid, and insulin glucose is made by doing engineering at B3 position, where aspargine is replaced by lysine, and in B29 lysine is replaced by glutamic acid. Just tweaking sequence of amino acid, adding few amino acid in place of other, led to their faster onset of action, faster peak, and shorter duration of action. What are the benefits of prandial insulin analog over human insulin? Few hypoglycemia effect, improved postprandial glucose control, better HbA1c outcome, proven superior efficacy in type 1 diabetes. Basal and long-acting insulin analog. Initially, for basal, in conventional insulin therapy, we have option of NPH or we have option of premix formulation like 30-70, 25-70, 30-70 and 50-50. But they were giving a lot of hypoglycemia, early morning hypoglycemia, Somogi effect. So then came insulin analog which are long-acting or ultra long-acting. The first is Glargine with the famous name Lantus and Xglar. Its time of onset is 1 to 2 hours. Time to peak is peakless. We know that it is a continuous uniform availability of insulin glargine in the blood. Then retimir and degludec. Degludec's time of onset is 1 hour. It is also peakless insulin. And duration of action extends from 42 hours to 4 days. So it gives a good chance of patient to change between the dose. Even if the patient misses the dose, he can take the next dose, and there is less glycemic variability. Insulin glargine is also made by doing engineering at A chain at 21 asparagine is replaced by glycine, and B chain elongated by 2 arginine. And similar things were done to the insulin detimir and degludec as well. Basal insulin analog, what is the key benefit? It provides long-acting stable insulin levels, control blood sugar between meals and overnight, superior to NPH in reducing nocturnal hypoglycemia, specifically the Somogi effect, and severe hypoglycemia. And in long-acting basal analog, we have glargine U300 and glargine U100. These are same molecule, but their concentration is different. U300 is a bit concentrated molecule, as you can see in the top of the chart that largely U300 is having 300 units of insulin in 1 ml. So smaller volume of injection is inserted into subcutaneous tissue. More compact subcutaneous record with a smaller surface area and more gradual and slower release from the epoch as compared to the U100. Insulin degludec, as I have already mentioned, that it is also one of the long-acting insulin analog, and it is very good and it creates very less chances of hypoglycemia. It is available in dihexamer, and when it goes into the subcutaneous tissue, it becomes multi-hexamer, and then degludec dimer and then monomer, it gradually goes into the circulation. Half-life is 25 hours, duration of action is more than 40 hours. There is steady state is achieved in 3 days, leading to titrated weekly rather than daily titration by NPH or other mix combination. One more insulin which is not available right now in India is Icodec or a weekly. This is once weekly insulin. It is developed to enable once weekly basal insulin dosing, and it improves adherence. It reaches a steady state in 3 to 4 weeks and maintains stable plasma level, reducing injection burden and better adherence. At the bottom, you can see how Icodec and insulin glargine they go and how is their profile. Icosema is also one another insulin in research in phase 3 trial that it is developed to get benefit beyond glycemic control such as obesity, CV and renal protection. Covers basal needs, semaglutide controls postprandial spikes and appetite. So it's a combination of weekly insulin and semaglutide, which is GLP-1 receptor. One more thing which is not here in the slide is insulin soliquor, which is having lexasenatide and insulin degludec in it. And simultaneously it is available in 133 formulation and 150 count. So with lexasenatide there will be weight loss and it will mask the effect of insulin, which is the anabolic form. Epsiltora is another molecule in pipeline developed to address the key limitation of daily insulin. Upcoming insulin are ORMD 0801 oral insulin, biochaperone, Nistro insulin, smart insulin, and Dragopil. These all are in pipeline, and there are no good results with the oral insulin right now. So to summarize that advantages of using analog insulin as faster onset of action, improved hypoglycemic control and flexible timing, and with a conventional therapy, if there is fixed treat pattern and patient is not affording, we can use the conventional insulin. They are also very good, and in clinical practice, mostly the conventional insulin are used. With this, I will finish my presentation. Thank you. Thanks a lot.
Right from the discovery of insulin, conventional insulin, and coming to the new onset and the insulins in the pipeline, sir has covered almost everything, every aspect of the insulin and its preparations. Just I would like to highlight over here, the use of conventional insulin is near about 70 to 75%. Now analogs since last decade, the use of analogs and basal insulin is increased. The advantages are definitely there in the analogs because they are more physiological, less risk of hypoglycemia. And there are studies which say that the risk of complications are less with the insulin analogs actually. So all the micro and macroosmolar complications they are used with the analogs as compared to conventional insulin. So definitely basal the analog insulins had got edge over the conventional insulin.
You say informative talk.
I request our chairpersons to kindly felicitate our speaker. I request Dr. Shafi sir to kindly felicitate our chairperson. So now we move to our next session. It is early insulinization, need of the hour. This session emphasizes why timely insulin initiation is important. I now call upon the chairpersons, Dr. Ramesh Sharma sir and Dr. Jabbar Patel sir to kindly chair the session. I call upon Dr. Ehsan Sheikh sir for the session. Sir is diabetologist at Diabetes Care Center from last 12 years. He is director at Diabetes Care Center and Khushi Women's Hospital in Chhatrapati Sambhajinagar, Maharashtra. Has been a regular speaker. Has participated in GUARD study of vildagliptin by Novartis, one of the investigator in landmark trial. Was in the organizing committee and a member of RSSDI. Sir is a very prominent speaker, and I hand over I request the chairperson to kindly introduce the topic.
Thank you, organizers. And introduction of Dr. Ehsan is already given. Everybody knows busiest diabetologist of the town. So topic now the session is early insulin initiation. It's a need of the hour. We know it. Insulin initiation is usually delayed. There's a very big inertia on the part of consultant, diabetologist, physician, whoever it is, and the patient part also. And it is required. If you want to reduce the chances of complication, say good control is must. And we are waiting step by pattern, increasing one by one tablets, one by one, like that. Then ultimately, then we decide to start insulin. So how fast, how early we can start insulin so that we can prevent the complications as well as we can preserve the beta cell function. So that's how the topic is very important, and I hand over this session to Dr. Ehsan to know what is how he can guide us how to start early insulin.
Good morning, sir. Respected chairs, my colleagues. At the outset, I would like to thank the organizers for the opportunity. Insulin is the need of the hour is my topic, and early insulin initiation need of the hour. So we know that India is the second capital of diabetic population, and still the 57% patients are undiagnosed, or the burden is increasing very fast. Besides that, actually, what is the why insulin? The Indian phenotype is really different. We have to focus because really the relatively early age of onset is the most worrisome fact.